introduce our keynote speaker, Dr. Christopher Gordon. Dr. Gordon is the Medical Director and Senior Vice President of Clinical Services at Advocates. He has taught on the faculty of Harvard Medical School since 1976, where he is Associate Professor of Psychiatry, teaches the residency program at Mass General and McLean Hospital. Dr. Gordon has an extensive background, which also includes co-leading Advocates in a groundbreaking adaptation of open dialogue, which is a state-of-the-art method of working with people experiencing psychosis. Please join me in welcoming Dr. Chris Gordon.
Thank you very much, Stephanie. We didn't pass out my slides, but my email address is on this slide. It's also on the last slide. It's pretty simple. It's cgordon@advocates.org. And if anyone would like to have my slides, I'd be delighted to share them with you. I'd just like to say how incredibly honored I am to have been asked to speak today and to share the program with such a wonderful group of presenters. And it looks like an awesome day. We're already off to a great start. That was quite an exercise we did together. I'm also really glad to have been asked to speak about something that's really close to my heart, something that I care very deeply about, which is the idea that if we provide truly person-centered, strength-based, trauma-informed care to people in a spirit of true warmth and neighborly hospitality, that we create safer environments for the persons served, for the people directly providing the services, for family members and other clients, and for the community at large. And my talk today is based on basically two ideas. That's the first one. And the second idea is that it really is possible to do serious, hard-nosed, effective risk management processes and still remain true to a person-centered approach and person-centered values. And my plan for the talk is I want to present some work that we've done at the company where I work, Advocates, based in Framingham. Advocates is one of many similar organizations, a full-service, non-profit human service agency that, like its sister organizations, in partnership with DMH, we're dedicated to the idea that people, regardless of their diagnosis, regardless of their disability, have a right and an ability to live full, self-directed lives of their own design in the community if they have the right kind of supports. So I want to share some work that we've done at Advocates, particularly focusing on how to keep our values kind of front and center in the process. Then I'd like to present to you 5 very modest ideas which kind of inform my own practice. Not that they're terribly original to me, they're not. At least a couple of them are oldies but goodies that you will recognize right off the bat. But I think maybe a couple are, I'm pretty confident you haven't heard of before, even though they're sort of like old wine and new skin. They're still very basic ideas. Then I'd like to highlight the role of direct service professionals and certified peer specialists in accomplishing these goals. And then say a few words about how we handle risk management at Advocates and how we try to detoxify the obnoxious aspects of risk management through the use of hospitality. So that's my goal. And I just want to say at the start that I have a little bit of a concern about this talk. And the concern that I have is I don't want it to come across like I sound like I know what I'm doing. I don't want it to come across, especially that like, at Advocates we do da-da-da, we're all that in a bag of chips. This is a journey, not a destination. We definitely do not have this solved, but we've been working hard on it for a long time, and I really want to kind of just share our process. So, and I want to acknowledge that So let's start by kind of remembering what the work's about. And that is, we want to create services that people experience as, and which truly are, really deeply respectful of people as full human beings, not defined by their diagnosis, not defined by their disability, but appreciated as real people with strengths, accomplishments, talents, skills, preferences, aversions, and especially with lots of expertise about themselves and what's best for them. And we want to create services in which people feel like they're empowered as full partners in their care, if not actually the primary driver of their care. I think it's also important to acknowledge that practically everybody we serve comes to us with a history of trauma, often very severe trauma. And the sad truth is that if the trauma didn't precede their experiences in the mental health system, all too often people have had awful experiences of trauma within the mental health system. Over the last several years, as Stephanie mentioned, I've been doing a lot of work with early episode psychosis. I see young people at the beginning of their psychiatric experience, but practically everybody I see has had some psychiatric experience, and I'm sorry to tell you, it's been almost always pretty tough. So I know when I meet somebody for the first time as a psychiatrist, they're looking at me through a certain lens, and I'm starting off with like 2.5 strikes against me. It's on me to prove I'm not an asshole. So, and the other thing, as I think Buddy mentioned, is we want to build relationships that are durable, that are there for the long run. We want to build authentic relationships so that, like a good marriage, it can stand some turbulence and trouble. So it's like from the very beginning, what our work is about is starting to lay down fiber optic communication cables between us and the person we're serving, so that when the going gets rough, we've got some money in the bank with each other and got some channels of communication open. And finally, with our partner DMH, we want to build whole systems of care that really promote recovery. So that's job one. Job two is to create risk management systems that reliably and accurately identify people who are really at higher risk for violence or self-injury or other worrisome factors. And having identified those risk factors, we then have to translate that information into a plan, ideally collaboratively built with the person receiving services, that is understandable and implementable by the direct service care professionals who spend the most time with the person. And that requires both a lot of skill in designing the plan. It also means investing a lot of time in our relationships, both among, between, and with direct service care professionals, so the people who are closest to the work really understand the risk and really understand what the plan is to address it. Am I making good sense? Some nodding? Yes, thank you. I'll be talking more about nodding in a minute. So, and let's just acknowledge that these two goals can sometimes be in tension, because the language and the feeling tone of person-centered care is neighborly, it's warm, it's friendly, it's open, it's congenial. And the language of risk management can often be pretty harsh and clinical and diagnostic. And if we're not careful in how we do our risk management, we can actually wind up re-traumatizing people in the process. So now I want to turn to the idea of how to keep our values in front of us all the time. And I know I said I was going to try to avoid sounding like at Advocates we've really got this down. But actually, I'm very, very proud of how we've handled this issue at Advocates, so I'm just going to reel it right out there. And what happened was in around 2006, we got the idea that it would be really a wise idea for us to be able to set down clearly and plainly what our values are and how those translate into clinical practice. So we created a task force. There's about 40 people and it involved people who received services from all over our company. It involved people who were involved in the direct provision of those services, as well as program managers and senior administrators. And we decided to start with a clean sheet of paper, and we made a commitment. We were going to meet every month for 2 hours until we had this thing done. And it took us 3 years to do it. But we wound up with something we call the Advocate's Way, which runs to about 7 pages written. We also made a video, which is awesome. And the video has an ASL insert, so that's about 22 minutes long. You sit down and watch the thing from start to finish. But the idea behind this project was twofold. One, we employ about 1,400 people at Advocates, so we've got a big turnover every year. And we didn't want our values to get lost. We wanted some way of orienting new staff. But the much more important value of this was to be able to show the video and show the document to people receiving services and their families so they could hold us accountable, which they definitely do. So I just want to give you a little feel for this. This is from the Advocate's Way. This is the very start of it. At Advocates, our work is based on our relationships. Relationships with the people we support, their families, others with whom we interact, and with each other. We want all of our relationships to be authentic, respectful, and caring. Our motto is, first we listen. And when you put that out to people and you screw up, you get back. You call that listening, which is fantastic. We start by listening as deeply and with as much empathy as we can to understand the person from their own point of view and in a way that honors the person's culture, values, and preferences. We appreciate the person's strengths, hopes, and the validity of their lived experience. When we provide services to people who have often not been listened to or respected in the past, we try especially hard to treat the person exactly as they want to be treated. And I can tell you our group went back and forth. Should that sentence be, we would treat the person as we would want the loved one to be treated, as we would want to be treated, or as the person wants to be treated. And after a lot of thought, we landed on exactly as the person wants to be treated. So I was going to read another one, but I think in interest of time, I'll just put it up there and let you read it at your leisure. But you can see how this is a way of keeping the values front and center. So we show this at all employee orientations. It's sort of like a communist re-education camp, because we read a paragraph or two at the beginning of a staff meeting and talk about it. And the same group, although the population has turned over, still meets every month to find places where we're succeeding in doing this and sending out a celebratory email to the whole company, but also being really curious about where we're missing the mark. And we've gone through 2 editions of the Advocate's Way as a result. So that's the idea of keeping values front and center. Now I would like to turn to the 5 modest ideas. And the first one is the good old biopsychosocial model, which I'm sure all of you have heard about a million times, thinking about people from a biopsychosocial point of view. But what I'd like to do, if you don't mind, is share with you a little bit about how I use this in my own practice. And I should mention that when I was 50, I became Jewish. And as a part of becoming Jewish, I got real interested in my own spiritual life. And as a result, when I was taking people's histories and talking to them, I started inquiring about whether or not they had any spiritual practice, or did you ever have spiritual practice? And it turned out to be an incredibly rich part of the conversation. So for me, I think of biopsychosocial spiritual as the model I employ. And what I love to do is, when I'm working with somebody, but we haven't gotten yet down to deciding what to do together, I say, you know, Mr. Jones, I wonder if it would be okay with you, before we decide what we're going to do together, if we take a couple of minutes, and if I could explain to you how I think about people. And that way you'll, not just my patients, but myself, my kids, my friends, anybody who's struggling with something, I'd like to share with you how I think about it. That way you'll know how I think, and it might be easier to put our heads together about what to do. I've had nobody turn me down on that offer. And then I say, okay, what I do is when I'm working with somebody, I start off by thinking first about the person's strengths and good qualities. Because I don't want to get swamped by problems, and I never want to lose sight of these good qualities. So Mr. Jones, in your case, I might say, and then I reel out 4 or 5 strengths, which it's always possible to find strengths in any human being. So we start off on a positive note. Then I say, after that, I try to think about the problems we've been talking about from 4 points of view. The first one is a social point of view. And that just means there's something going on in this person's life that is making them miserable, making them anxious, driving them crazy. It could be anything, a terrible problem in the marriage or at work, anything that's going on now. And I also ask myself, has something in the past happened to this person that is really important for me to bear in mind, maybe that didn't get dealt with thoroughly? So that's the social point of view. Then I think about the psychological point of view, which can sound kind of fancy, but really all it is how has this person coped with what has happened to them? Because sometimes the way that we cope with problems become problems of their own. And an example of that would be a person who had been hurt really badly as a child, who discovered that alcohol soothes the hurt, and then the alcohol becomes a problem in and of itself. So that's the psychological model. Then the biological model, I don't want to waste my folks' money from going to medical school, so I think about, could there be a chemical contribution to this problem in some way? And then the fourth way I think about things, which is not relevant to everybody, but it's very relevant to some people, is spiritual. Like somebody had a crisis of faith. And then I say, Mr. Jones, do these 4 ways of thinking about people make sense to you? Do you relate to them? And practically everybody says yes. And I think the reason is because the way I've at least tried to convey this is very, very non-pathologizing. It's very, I'm kind of describing the human condition. And then, if the person says yes, then I can ask the $64,000 question, which is, Mr. Jones, which, if any, or some combination of these models do you think is the best way for us to start to think about the things we've been talking about together? And that way, I hear the person's point of view first. And it's marvelous, because it opens the door to a really, really good collaborative conversation. And if, for example, the person has all the signs and symptoms of depression and has 3 aunts and 4 cousins with depression and has had severe depression in the past, and I'm thinking, wow, poster child for antidepressants. And I ask which models make the most sense, and the person says, well, I think the psychological and the spiritual. And I can say, that's interesting, not biological. The person can say back to me, don't even go there. I know you shrinks, and all you want to do is push pills. And that way the problem comes on the table openly, rather than as it might have done if I had put my foot in my mouth and said, you know, Mrs. Smith, you could be a poster child for antidepressants, in which case the game is basically over. So, sound good?
Yep.
Okay. Second, this is a little more idiosyncratic to me, but it's called get the nod. And that just means that when I'm talking to somebody, I'm looking for the nod. And a few of you guys, not all, have been very nice nodders during my remarks so far. Because I can tell you, when I'm talking to somebody and I'm getting the nod, I don't know if they're feeling better, but I'm definitely feeling better. My blood pressure goes down, my pulse slows down. Why? Because I feel like there's rapport in the room. And if I don't get the nod, I get nervous and anxious because I'm worried that either I have missed something, I've said something, I've offended them in some way. So to me, the nod is a barometer of rapport, and if I don't have rapport, I'm basically out of business. And some of the tips I can offer for getting the nod are, number one, to use just a neighborly tone of voice and demeanor. You know, for me, I get super points from people for just being ordinarily nice. It's amazing how low the bar is. You know, people are, when they meet a new psychiatrist, they're bracing themselves. Oh God, I hope it's not an asshole. And you know, just by not being that way, it's often not worthy. The other thing is to be careful about harmful, shaming words. In psychiatry, we throw words around like psychosis, hallucinations, delusions, which can be very hurtful. So find a neighborly frame of reference. And then the other tip that I would offer is use the same words. So if Mr. Jones says to me, you know, I've been fighting with my wife every single day, I'm at the end of my rope. And I say, so let me see if I understand what you're saying, Mr. Jones. You've been arguing a lot with your wife and you're really not sure what to do next. Nod worthy? No, that's not nod worthy. Whereas if I say, Mr. Jones, if I hear you right, you've been fighting with your wife every single day and you are absolutely at the end of your rope. You guys agree that that is more nod worthy? I'm looking for nodding. So I think what's happening there is that on an unconscious level, the other person is, a little bing is going off. Because in order to use the same words, you actually have to have been listening in the first place. So, and the experience of somebody actually listening to you is very rare. It's like, oh, wow. This person is listening. Okay, so that's the second one. Now the third one, which is also idiosyncratic to me, it's not an original idea, but it's the idea of finding an edge. Now let me ask you guys, do you all know what a magic eye picture is? Where it looks like it's just a foggy picture, and you put your nose up to it and you gradually move it away and said, bing, a three-dimensional object appears. People know what I'm talking about. Okay, so the idea here is that when we try to talk to people about an issue that we see as a problem, but the other person doesn't see it as a problem, then it's like they're seeing the foggy magic eye thing. So if I go into an emergency room and I'm seeing Mr. Jones, who got arrested for running down the street naked and had a blood alcohol level of 350, and I launch into some discussion about his alcohol problem, but he doesn't think he's got an alcohol problem. What's very likely to happen, and I imagine your experience would bear this out too, Mr. Jones is likely to feel insulted, defensive, humiliated, and very little good is likely to happen. So the idea here is that when we're talking about people and trying to treatment plan, we have to make sure that we're talking about a problem that has an edge, that there is a three-dimensional thing that we can be talking about. And so in terms of risk management, that means we got to keep backing up until we find something we can agree about. And one of the ways in which I like to think about this is keeping in mind the difference between limit setting and giving somebody a heads up. Giving somebody a heads up is a good way of starting to try to find an edge. So for example, I might say, you know, Mr. Jones, as we're talking about the difficulties that have been going on in your life, I just have this awful feeling, and the feeling is like you're sitting in a car stalled on the train tracks, and I hear a train coming, and I want to give you a heads up about it. That's so different from saying, I'm going to set limits on your behavior. I'm going to tell you what to do and not do. Now this one, I'm absolutely confident is new for at least a lot of people in the room. Does anybody here know what Zim Zoom is? No nodding. In this case, that's good. So when I became Jewish when I was 50, I learned about all kinds of interesting stuff about Judaism, and I learned about this idea of Zim Zoom. And Zim Zoom was an idea that the rabbis in the 15th century, 16th century, were knocking around. And the question was, that interested the rabbis, was if before the world was created, God was everywhere and in everything, where was there room for the world? And the answer was God had to contract herself or himself to make space for the world. And a corollary of this idea was that God wanted to create human beings with whom God could have a real relationship. That is to say, God is omnipotent, so God could create us where we all constantly praise God and love God. But that wouldn't feel very good to God because it would be automatic. What's desired instead is love freely given. So therefore, God had to withdraw her authority or his authority over human beings in order for us to be free to love or not love. Am I making sense? So the corollary there then for us is not that doctors are like God, but rather that whenever there's a power differential in a relationship, it's toxic to intimacy. And the person with the higher power has got to practice Zim Zoom, has got to get down, has got to diminish his or her authority so there's room for a real relationship. So for doctors, that translates into, I shouldn't call Mr. Jones Tommy if I'm expecting Mr. Jones to call me Dr. Gordon. My calling him Mr. Jones or offering for him to call me Chris was a way of practicing Zim Zoom. But the more common practice of Zim Zoom is simply to feel and really act as if the other person is a true co-expert about his or her own life, and giving up some of the trappings of professional power that otherwise might make a real relationship difficult. So those are the four ideas. Now the fifth idea is from my old beloved mentor, Aaron Lazar. Aaron Lazar, blessed memory, was, I think, the best psychiatrist I ever knew. Certainly the kindest, most down to earth. But Aaron came up with this idea in the 1970s that we should treat our patients as customers. And this was back when I was in training at Mass General, and Aaron was at Mass General, and all the docs were scandalized by this idea that I do not treat my patients as a customer because I have a doctor-patient relationship. It's sacred. And it is. However, as Aaron pointed out, in the doctor-patient relationship, at least then, the doctor had the power. Whereas in a customer relationship, the customer has the power. And it's incumbent upon us to figure out what the customer wants, what the customer needs, how the customer wants services developed to be delivered. And it's actually very, very refreshing. And I think it's kind of cool that if you practice great customer service with the people we're supporting, you kind of automatically get the nod. You automatically find out where the edge is, and you automatically practice Zim Zoom. So I'm a big fan of excellent customer service. So now I want to just turn my attention to the direct service care professional and make just a couple of observations. My colleague at Advocates, Beth Lacey, who runs all of our clinical services, says that the hardest job in our company is the program manager, because she or he has got to do 50 zillion different things. Got to interact with funders, keep the budget on track, make sure the house is clean, and lead the staff. But I just want to highlight that the idea of really forming a an empowered team with direct service care professionals is really job one, because the direct service care professional is both a key customer representative of our company. They're the person closest to the work, and they are critically important customers in their own right. To that end, nothing is more important than having really good staff meetings where direct care service professionals feel there's space, time, and room to ask questions, to give input, to make suggestions, and to make sure that the risk management plan is really, truly well understood. I also would like to give a nod to certified peer specialists. I've been a clinical psychiatrist for over 40 years, and I have to say that the biggest change that I have seen in our field in the 42 years of my practice has been the presence of certified peer specialists. If I were to go back in my time machine to my training and compare now to then, the biggest single difference is that if I am working with a young person with an early episode of psychosis, and I wanted to connect that person with someone who has actually been there before, who was actually hospitalized, actually took medicine, actually was sectioned, and is now living a full, complex life of recovery, that's possible now, and it was completely impossible before there were certified peer specialists. Before there were certified peer specialists, people who recovered tended to disappear because it felt so shameful to acknowledge the stigma of mental illness. And I want to highlight, I think it's really great. I myself suffer from pretty bad depression and anxiety. I take a psychiatric medication. I've had a ton of psychotherapy, and I'm a grateful recipient. And I describe patients when we do the 4 models, I say to them, I'm firing on all 4 myself. And I happen to be both the hair club president as well as a client. So things have really changed in the 40 years because there are a lot more people like me who are out there, who are providing services but are also open about our own histories, which has also really changed, which is marvelous. But I just want to say that's not the same as a certified peer specialist. The certified peer specialists, at least the advocates, they can talk to people in a way I simply cannot. And it's because, at least in our company, they are not in clinical roles. They're just there to amplify the voice of the person receiving services and to be a hope generator. They also wear an additional hat of being human rights officers, but they're just super powerful voices and promoting recovery. I think I'm running behind on time, so I'm going to have to go a little fast to cover my territory. I wanted to talking about difficult matters, and I was hoping to draw a little bit from our work on open dialogue in that process. Because when we do risk management, with engaging with people who have serious risk histories, we often do have to talk about very difficult aspects of their history. And one of the tools of open dialogue is having family meetings in which everyone speaks openly about their thoughts and concerns about the problem at hand, and in which there are always at least 2 clinicians. And one of the modalities which we use is talking about something before we talk about it. So we would say, if there were 2 clinicians and Mr. Jones was with us, and we were concerned about Mr. Jones's history of violence and his history of self-injury, we might come at that topic by my saying to my colleague, I feel my stomach's a little bit in a knot because I'm wondering what it would be like for Mr. Jones if I brought up now the issue of his risk history. I'm wondering what it would be like for him, for me to ask him about the episodes which led to his last hospitalization. This way of talking about something is a way of easing into difficult topics. And again, it has qualities of finding, I have until 10:45. Oh, thank you. Okay. That's good to know. So the other thing is that I will often do is I'll say to somebody, I know I'm a stranger to you, and I know what I want to ask you. What I want to ask you about now is pretty personal and pretty difficult. And I wonder, would it be okay with you if I asked you? And by giving the person the permission to say no, I can say, okay, that's fine. At some point in the next 3 or 4 days, it's important that we have this conversation. So let's try to find a time that works for you. But to try to give the person as much control and as much choice as possible. The other thing that's good about asking whether it's okay to talk about something difficult, in my experience, is that the person always thinks you're going to ask about something worse than you're actually going to ask them. So the person sort of braces themselves, okay, all right, what is it? And then you say what it is, and they go, oh, that's all. So it works on a lot of levels. So now I'd like to talk about the risk management system at Advocates, which in many ways is very, very similar to the risk management system in all of our sister organizations. It's more alike than different, but there is one important difference that I want to highlight, and that is, we start with a standard intake evaluation, as everyone does in CBFS services, as we will soon do in the new ACCS adventure. We have a standard intake evaluation, but we do have an expert team that adds to the evaluation when risk factors are identified, and that expert team is responsible for constructing a crisis plan. But what's a little particular to Advocates is we then assign a risk rating to everybody whom we serve, high, medium, or routine. And there is what we call an extraordinary historical risk modifier, which is an asterisk. And the asterisk, the extraordinary historical risk asterisk, stands for that there is something in this person's history that we never, ever want to forget. And yet at the same time, we don't want to be constantly reminding the person about it and putting it in their face. So one example might be a woman who 20 years ago committed an infanticide, killed her infant in a state of postpartum depression, but has not had a recurrence since. That person might very well be at a routine level of risk, but with the asterisk, so that if that person becomes seriously depressed or goes into crisis, we're signaled that there's something in the history that's very important. A more practical and sort of more useful one would be if there's a person we're serving who has had a history of violence against a staff member and has a high risk rating on that account, that person would also have an asterisk. So that if you are a direct care service professional and you come into a program maybe as a relief professional, you're able to identify immediately, are there people I'm serving tonight who are regarded as having high risk? Are there people I'm serving tonight who have special historical factors that I should be aware of? So it's also part of our practice that anybody who has either a high risk rating or an extraordinary historical risk rating, those people must have a collaboratively written crisis plan. And if they do not have a collaboratively written crisis plan because the person refuses to collaborate, then we have what we call a staff action plan, which is the plan that we've created unilaterally. And it's our practice then to show the person the staff action plan, or at least try to, and invite the person to help us improve it. So we make it as collaborative as possible. So the pluses and minuses of this system are that if you're a direct care service professional, as I've mentioned, not only can you identify who am I serving who might have a serious risk, an elevated level of risk concern in current time, and who am I serving who has historical risk factors I should be aware of, or both. And I can immediately access a crisis plan to know how to manage this. So under ideal circumstances, this would help direct care service professionals make better decisions about whether or not it's safe to work alone, for example. So that's the plus. The negatives of this system are, number one, it's very hard to maintain it. It's very hard to keep the crisis plans up to date and the risk ratings up to date. It takes a lot of work. But the worst thing about it is that the people we serve don't like it. And they don't like it because it's experienced as one more stigmatizing label. You know, it's not bad enough that you've labeled me diagnostically. Now you're labeling me high risk. It feels demeaning. It feels degrading. And we went round and around about this. Was there any way we could sort of detoxify it? And one of the ways we considered detoxifying it was to, instead of calling it risk, call it concern. That a person is high concern. And the rationale behind that language was that concern lives in me. It doesn't live in you. So I'm expressing my concern. And believe me when I tell you, at Advocates, we can process something like that forever. So we went back and forth and back and forth. And we finally decided to stick with risk, even though it's more obnoxious, because it conveys more concern than concern conveys concern. We were afraid that, especially direct care service professionals, would not see it as serious. So we've stuck with it. So now I just want to say a few words about detoxifying the clinical risk system of its obnoxious qualities, including that kind of language. And I want to acknowledge that one of my mentors and one of my friends is a person who directly receives services from us in our CBFS program. And about 8 years ago, he came to my office to scold me for not knowing about open dialogue and not knowing about Robert Whitaker. And ever since then, he's played that role in my life. He's a scold. He's always finding things I'm doing wrong, and he has the bad taste to be right practically all the time. And I have his permission to use his name, and so I'm going to use his name. His name is Glenn Malloy. And Glenn is a man who psychiatrists would say has bipolar disorder, because he goes in and out of the hospital. And he receives CBFS services, and he has a lot of trouble in his life. From his own point of view, when he is what we would describe as manic, he is basically intoxicated by God. He's filled with the Spirit of God. Glenn belongs to 3 or 4 different churches and at least one synagogue in which he is a very, very highly valued member of the congregation. And he describes his depressive episodes as spiritual hibernation. So in my life, Glenn has, I like to describe him as a cross between a saint and a hemorrhoid. Because he has been this wonderful, terrible, inspiring scold. We now have open dialogue at Advocates basically because of Glenn. But Glenn has taught me to think about our services as being an opportunity to practice radical hospitality. And as a Christian, he believes that that is one of the great human opportunities that we have with each other, to practice hospitality, to when a person is suffering, to treat them in a welcoming way, a warm way, to offer tea, to offer succor, simply to offer warmth and care. And this stands in pretty stark contrast to the misapplied medical model. So I'm gonna take a few shots at some straw men here now. These are, because these are sort of cartoons. But when the medical model is misapplied, the doctor really behaves as if the power differential either doesn't need to be addressed or it's inconsequential, and just practices from a posture of heightened power. And that's really captured beautifully in the idea of doctors' orders, doctors giving orders. And I can't tell you how many times I've been in conversations with doctors about treating people with the diagnosis of schizophrenia, about what you should prescribe under which circumstances. And under these circumstances you should prescribe this, under those circumstances you should prescribe that. Not under these circumstances a well-informed person might think about making this decision or that decision. Rather, the center of gravity is in the physician, which is a deep, deep error. The center of gravity should be in the person receiving the services. The other thing that we doctors love to do is engage in polysyllabic guild language. And we can talk about people, or talk about mental health conditions, or talk about the neuroanatomy in ways that makes it seem like you absolutely have to have a graduate degree in order to even have a seat at the table. And that is bullshit. It is baloney. And yes, these things are complicated, but they are all translatable into plain English. And the choices which people have, and the risks and benefits of the medications from which they have to choose, can be talked about in ordinary language. The clinical gaze. I wish I knew who had taught me about the clinical gaze, because it's a really, really important idea. And the clinical gaze is when a doctor is looking at you and you can see that the doctor is running scripts in his or her mind about the differential diagnosis and what's the right diagnosis. Do you guys, how many of you guys saw the original Terminator? Remember when the robot Arnold Schwarzenegger is sitting in the hotel room and the landlord is banging on the door, and Arnold Schwarzenegger is running scripts about how he's going to respond to the landlord, and he finally comes up with something like, "Get out, asshole." But anyway, the idea of a robot running scripts is the idea of the clinical gaze. It happens when we look at people as an object. And I don't know if you've ever had the experience of being looked at this way. I have. Back when I was first consulting a psychiatrist for a psychopharm consult. And he turned out to be an absolutely awesome psychiatrist, but he barely made it to a second interview with me, because I felt like he was looking at me with the clinical gaze. And at one point he said to me, "Yes, I've known people like you before." You hear it? People like you? So the clinical gaze is really bad. And it often goes with demeaning language. Speaking about people as if their diagnosis defined them, Yeah, we had a new admission last night. Chronic schizophrenic. Horrible. So we strive for person-first language all the time. So other factors, no real options, no real respect, bossing people around, pathologizing people. And I just want to say that, you know, for practitioners of the healing arts, we have some really good traditions, really good history we can fall back on. And this is especially true of our nursing colleagues who have a lot to teach us. I know when I was a medical student, it blew my mind when I was up on the medical floors with people who were gravely ill and having to expose their bodies to us and to deal with feces and blood and pus and other bodily fluids, and to watch the way the nurses interacted with people, their kindness, their immediacy, the softness of their touch. These are part of our heritage that we can fall back on. The idea that nothing is going to turn us off enough to step away from the relationship. No amount of pain, not even death. These are great traditions. There's also in our tradition a basic optimism that life is good and that caring for each other and being together as doctor and provider is a good part of life. So the idea, the bottom line is for us all to be the direct service professional, nurse, doctor, social worker that we would like to have for ourselves. So here's my summary, and with that, I'll bring my remarks to a close. Thank you for paying attention to me. And also, thank you for nodding. I'm told that there is time for a couple of questions, if anybody would care to ask one.
Would you mind just putting up your summary while you're talking?
Yes.
Because I would like to read it. Thank
Yes.
you.
Anybody want to ask a question or make a comment? No? Nothing? Nada? You say?
Dr. Gordon,
Yes?
I just have to say that I've heard you speak before, and I'm definitely a fan of what you're talking about. So I could not do the whole presentation. I just appreciate you being here and sharing your ideas with us. I definitely want to, I'll be emailing you.
Thank you. Thank you so much.
Thank you.
You know, they say that public speaking is the number one thing that people are dread in the world, and I gotta tell you, I was worried sick about getting up and talking in front of you guys, and now I'm thinking, what was I so worried about? So nice and friendly, and I'm so glad I was here. So thank you again for having me. Oh.
I just wanted to ask, so you talked about the work in advocates to embrace, to define and then embrace kind of an approach you describe it. You know, clearly there's a lot of unlearning. You know, I think of all of our professional disciplines, or just how we trained and thought about this work, and you know, for our state workforce, one of our real strengths is longevity. So we have continuity, but with longevity also means that people have learned their skills, and the world has changed rapidly in terms of our thinking about what is effective and how to. So how do you go through the unlearning part in order to be opened up to
That's a
new way of
beautiful
using your
question. So,
skill?
Buddy's saying if you have longevity in your staff, and some of these ideas are a little at odds with what we learned back in the day, how do we deal with the new learning? That's a great question. And it's true at Advocates that that the leadership. I've been there 22 years, and on the senior management, the senior management team, I'm the new kid on the block because our people have been there longer than I. But I think one of the things that's been so incredibly powerful in terms of game changing is the certified peer specialists. You know, that it's so eye-opening because we employ over 30 certified peer specialists, and those are 30 some odd people with 30 some odd different pathways to recovery. Some very traditional and conventional, found the right meds, enjoy the benefits. Others who have found their way to recovery through very unconventional pathways. And it's both inspiring and it's humbling to realize that there are a lot of different ways through the woods. The other thing is, you know, our Advocates Way video, the way it works is we've got like 40 different people to each read one paragraph, and you see the person, and then you hear what's read. I know I'm prejudiced, but I think it's just so inspiring to hear it coming from all different parts of the company. And you know, I think our medical team may have been a little slow to adapt the Advocates Way, but slowly it gets absorbed. Any other questions? Yes, sorry.
How do you feel about the recent decline with all these shootings and the media jumping on, blaming gun control instead of focusing on the lack of budget going into the mental health situation?
Yeah, well, I worry terribly. I'm sorry?
I find it unnerving.
Yes, I find it unnerving too. You know, I feel terrible about the way that it has inflamed the stigma against people we serve. And to the extent that it sometimes does awaken a knowledge that we need to support more services for people with mental health conditions in the community, that's good. Personally, I feel like it's a false dichotomy that is between the issue of gun control and better mental health services. For me personally, I feel like it's insane that we don't have better gun control, better safety mechanisms to limit access to high magazine guns. But I worry mostly about the stigmatizing effect on people with mental health conditions. Okay, well, thank you again.